and taking care of thousands of women. And I really see the way we practice reproductive endocrinology and IVF is changing in that I think there's more options for women. You should know your options, and there's many more options in fertility treatment and IVF than just very high-dose, rigorous IVF. I really think almost that should be starting to be a thing of the past. I think traditional clinics, they have one-size-fits-all protocol that they use for IVF, which tends to be those higher injections, multiple injections a day. And for women over 40 or women with low AMH, they really need more nuanced care. I think it is important to understand that although we don't have to say it's a cliff, it's definitely a sharp curve after age 35, and it becomes much more dramatic after age 40. I do think it's so important to understand the impact of age on egg quality and keep that in mind when you're planning your family size.
I'm really excited to introduce Dr. Jennifer Kulp-Makarov, a board-certified endocrinologist trained at Johns Hopkins and Yale. We previously collaborated on a Yoga for Fertility workshop. Welcome, Dr. Jen, and I'm going to call you Dr.
Yes.
Jen because we've known each other for quite some time. As mentioned, you trained at world-renowned institutions, Johns Hopkins and Yale. What was the catalyst for you to get into fertility medicine and specifically reproductive endocrinology and infertility?
Yeah, so, I was always interested in the science behind it when I was in school. The science behind this, it just blew my mind how this complex process could lead to creating a life. So that's what really sparked my interest in the beginning. And then I also have a deep love of women's health. So that's what I would say really kept me in the field, is taking care of women, and that combined with the science behind IVF is really the two things.
Was there a defining patient experience that shaped how you practice medicine today?
Yeah, I think so. Today, I've really had a journey as a reproductive endocrinologist. I've been in practice for many years and taking care of thousands of women. And I really see the way we practice reproductive endocrinology and IVF is changing in that I think there's more options for women. And one patient that really stood with me was a woman who told me that she didn't complete her family because she was concerned about sort of the rigors of IVF and the high-dose medications that are used during IVF. And that really, stuck with me and changed how I felt, because I really felt like that should never be the case. You should never, at least you should know your options, and there's many more options in fertility treatment and IVF than just very high-dose, rigorous IVF. I really think almost that should be starting to be a thing of the past, but that really stuck with me, that was the only thing she knew about fertility treatment, and that prevented her from growing her family to the size that she desired.
So you now focus on women with low AMH and women who are trying to conceive over 40. What were traditional clinics getting wrong for those patients, and how has this helped you shape Fleura Fertility?
Yeah, so I think traditional clinics, they have sort of a one-size-fits-all protocol that they use for IVF, which tends to be those higher injections, multiple injections a day. And for women over 40 or women with low AMH, they really need more nuanced care. It really makes a big difference in their outcomes and their experience of fertility treatment. And I think that's something that inspired me to build Fleura Fertility, that and also the patient experience, the overall experience, and the bigger clinics or more private equity-based clinics. I think there's something lost in those big clinics and the patient experience. So that was another big driver for me as well.
Mm-hmm. How does the patient experience differ when care is more individualized and relationship-driven?
Yeah, so I think when the doctor knows the patient, knows their history, and it's not being managed by a big group of doctors, I think that really makes a big difference. And I think when the protocols can be more tailored to the patient's biology, maybe their past their past IVF cycles, if there's that attention to that detail, which really comes in a smaller setting, it can really make a big difference in the patient's experience and their understanding of the treatment. That also allows them to stay better engaged with the treatment as well when they're not feeling like a number or not seen and heard. I think that's been a big problem with IVF in the past and fertility treatment in the past.
What is the Goldilocks approach to stimulation, and can you explain what that means and who benefits most?
Yeah, so the Goldilocks approach is something to stimulation, to IVF stimulation or fertility medications is something that I've developed over many years of practice. Honestly, I think any woman who's doing fertility treatment could benefit from this approach because what it does is it takes so there's a standard way of doing IVF, which is very high dose multiple injections. That's still widely practiced. And then there's the other extreme, which is mini, which is no injections at all. But I really think a middle ground approach is better, where you want just the right dose of medications to get a good quality group of eggs to grow. And you do that by adjusting medications through the cycle, by looking at the hormones through the cycle and getting a just right dose of medications, which honestly tends to be less intense, not so many injections. But it's also an approach that looks at, okay, if the eggs need some injections, we'll use injections, but it tends to be a more moderate dose, and that really works well for most women, I would say, but especially important for women over at age 40 or over doing IVF or women with low AMH, because those higher dose protocols often can backfire for that group of women.
Mm-hmm.
Yeah.
So now many women over 38 and 40 are told they need aggressive stimulation. When might less be actually more?
Yeah, I mean, I think especially I've had many patients come to me where they've had very high doses because the thinking is we should push more medications. The eggs aren't responding. We need to push more heavy medications and then the eggs will respond. But what can actually happen is that it's almost like the eggs get really overwhelmed by that high dose and they stop growing altogether. So, the more extreme cases is I've seen patients who've come to me with canceled cycles and say, you can't respond to IVF. It's not an option for you. You should start looking at other options. And really what they needed is that more nuanced approach because the eggs can grow if they're given, again, just that just right approach, really looking at FSH levels throughout and doing a just right, not overdoing it approach.
Are there specific biomarkers you rely on beyond AMH and age?
Yeah, so I do also look at something called AFC or antral follicle count. Mm-hmm. So that's a group of eggs that will grow up every month that you can see on ultrasound. They're best seen at the beginning of your cycle. I do find that's very helpful as well, looking at that group of eggs. Also looking at baseline estrogen, FSH levels, and then taking a look at those FSH levels through the cycle, because FSH in a way is a hormone that sort of feeds the growing eggs. And you want that at a medium level, that just right level. You don't want it to be too low or too high for eggs to grow really well. So it's really taking a look at that marker, that FSH through the cycle, also at baseline, but in addition, all through the cycle. So you're always adjusting to what's best for that cohort of eggs.
What role does FSH dosing play in egg competence?
So the FSH is like the fertilizer for the eggs. So, but if you overdo it, you can push a few of the eggs to grow ahead of the rest of the cohort. So it is really, we kind of almost say the fertilizer, the growth for the egg. It helps the eggs grow, but it's really. You get best outcomes if it's very carefully dosed and looked at.
How does age impact egg quality at a cellular level?
So age does impact egg quality in terms of whether once the egg fertilizes, will the chromosome complement be normal, will be the correct chromosome complement. That is how age impacts that. And that is something that obviously we can't change. You can't change your age. But given that factor, we can change sort of the protocols, the approach, and optimize the environment for the eggs. And that can meaningfully change outcomes for fertility.
What should women over 35 understand about fertility timelines?
So I think it is important to understand that although we don't have to say it's a cliff, it's definitely a sharp curve after age 35, and it becomes much more dramatic after age 40. So I think it's important to have that knowledge, be aware of that when taking into account your timeline, your fertility plans, that once it happens, once we get that diminished egg, the ability of the eggs to function well, to grow into an embryo of pregnancy, it can be hard to reverse that. So I think it's important to have that knowledge that it's happening, and be aware of that when you're planning your fertility or future family.
How does treatment strategy differ after age 40?
So after age 40, it's really important to look at these different markers like your AMH, your AFC, your egg count at the beginning of the cycle. Some women will do okay with a little bit higher dose protocols, but a lot of women, if they are not given a very individualized approach, really will not have as good outcomes. And I think it's really important to look at that and look at where you're getting your care and make sure, are they able to do that for you rather than giving a more standardized approach. I think it's also important, if a cycle didn't go well, to understand that it may have been the approach that was used, and there's different ways to approach and that you could change, and it doesn't mean it's you or just because of your age the treatment's not going to work.
Mm-hmm. There has been increasing interest in ovarian PRP. What does current evidence suggest about its effectiveness?
So ovarian PRP is where, from a blood draw, you're taking PRP, putting it into the ovaries. Current evidence is showing it can improve some markers like the antral follicle count or AMH. The current data is not showing yet improvements in, say, pregnancy outcomes. I will say I have used it a lot clinically in my patients, and I see promise in that area. We're increasing embryo euploid or competent embryos. And so I'm very hopeful for it, but the large studies, we still need those showing improvements in pregnancy outcomes.
Which patients may be most appropriate candidates for PRP?
So most appropriate candidates are women with low AMH, specifically if they've been I find if they've had poor outcomes in their fertility treatment in the past, or women over age 40, because it is looking to address that equality. It's looking at getting at that, supporting the eggs. And so that's where I find it most helpful. So specifically in those patients or younger patients who have had maybe poor IVF outcomes in the past.
Rapamycin has generated buzz in fertility medicine. What do we currently understand about its potential role?
Yeah, so rapamycin, I would say, is even newer, not as widely used clinically as ovarian PRP, but it is showing promise. So it's showing promise in protecting the egg cohort or the group of eggs. So it's showing promise in possibly delaying menopause. Again, these are very early studies, or in women with low egg reserve. So something we call POI, or premature ovarian insufficiency, where they have a smaller group of eggs than they would be expected to have for their age, that protects that group of eggs from getting depleted further. So this is where it's showing promise. There was also a promising study looking at rapamycin in patients with endometriosis to improve IVF outcomes and pregnancy rates. So that was, again, one study. So it's more limited, the data, but it is showing promise. There is a lot of buzz about it for fertility, and for a good reason. Yeah.
Good to know. So you frequently work with clients who have experienced failed cycles and recurrent pregnancy losses. How do you approach these complex cases differently?
So I think it's really important to do a deep dive into first the biology, looking at the previous cycles, looking at the stimulation, the trigger medication, then look at the embryology lab. So there's lots we can look at in the embryology lab with failed cycles, like the fertilization, the embryo growth, how the embryos were tested with PGTA testing. So you really want to do a deep dive into all these factors just to look for areas of improvement or where we can change strategy. Because I think what doesn't help is just trying the same thing if you're not getting good outcomes.
What signals indicate a protocol adjustment is needed versus continuing a similar approach?
So I think based on factors like your AMH, your antral follicle count, your age, when I look at those factors, I have a prediction in my head of how many eggs I expect to get, how many embryos, and how many euploid embryos I would expect to get. So if we're in that expected range for your age and AMH, then I think maybe it's not so much about tweaking the protocol. If we're off from what I would expect based on your age and AMH, that's where I want to really look at changing the strategy.
Patients often assume all IVF labs are equal, but what should patients know about lab quality and embryology expertise?
Yeah, so I think these days there is high quality across the board in embryology labs, I will say. It's very different than maybe 10 or 20 years ago where we did see a wide variation. I think there is high standards across the industry in embryology labs. That being said, you can look at pregnancy outcomes for the embryology lab, which can be helpful. I would just caution there that for clinics who focus on women with low AMH or premature ovarian insufficiency, by nature, they're not going to have as high pregnancy outcomes. So you also have to look at the patient population that's served by that lab when you're looking at that data. It's important.
What specific questions should patients ask when choosing a fertility center?
So I think they should ask about how often they're treating patients at their age. Do they have personalized protocols, or is it more standardized one protocol? You could ask about who owns a fertility clinic. I know this is no one asks that much, but for me, I think it makes a difference in patient care.
Private
if it's
equity
owned by private equity, big business, it's just the care may be different than if it's a smaller clinic or doctor-owned clinic. I do think there's variations in care there. So there's some things you could think about asking.
Mm-hmm. How has fertility care evolved to better support LGBTQ individuals and diverse family structures?
Yeah, so I think, it's evolved from more like heteronormative treatment where focusing on infertility to looking more inclusive. What are your fertility options, whether that's reciprocal IVF, we're looking at donor sperm, looking at what is your fertility journey and planning look at, and not just focusing it on infertility, because that's not what's going on in this population.
Yes.
Yeah.
What considerations are unique when designing treatment plans for LGBTQ treatment?
I think it's really important that inclusive vocabulary, intake forms, these are really important. I think it's important to understand that these people are not coming from a place of infertility. They could be very fertile. And so that's really important to keep in mind when designing treatment plans.
How can clinicians create more inclusive fertility environments?
Yeah, I think it's really important looking at intake forms, vocabulary used by the clinic staff. I think these things are important in creating a more inclusive environment.
What advancements in AI for reproductive medicine are most promising over the next 5 to 10 years?
So I think some of the advances in standardizing the large amount of data that REs are taking in, whether that's even from follicular scanning with the ultrasound, there's AI advancements in that, which standardizes it more. Right now, it can be a bit operator dependent, depending on who's doing the ultrasound. So I think there's standardization there. I think there's standardization, AI is showing some promise in helping with like these embryo time-lapse videos we have, where there's lots of information there about how the embryo grew over the course of its growth in the days in the embryology lab. And I think AI would help synthesize some of that data for the RE to look at. But I think ultimately it's still the RE should be making the decisions on these things.
Absolutely.
Yeah.
Ready for some rapid fire?
Okay.
Most underrated factor influencing fertility?
So I would say that's protocols and personalized protocols for IVF.
Most overhyped fertility trend right now?
I will say back to AI. I think some of the fertility AI shows promise, but it's not real world yet.
Good to know because there's so much hype
there's so
online,
much hype.
right?
Yeah.
One lifestyle habit that meaningfully impacts egg quality.
Yeah, so I do think looking at like your metabolic health is showing a lot of promise for impacting egg quality.
Yes. Biggest mistake patients make when selecting a clinic?
I think that's not asking about the type of protocols and whether they're individualized or personalized for each patient rather than a standardized IVF protocol.
These insights are so important, no doubt. One message you wish every woman understood earlier about fertility?
I do think it's so important to understand the impact of age on egg quality and keep that in mind when you're planning your family size. I think that's spoken a lot about a lot more, but I don't think the message is fully out there.
Because this podcast focuses on dismantling limiting beliefs, what is one belief you personally had to dismantle based on your life or career?
Yeah, I think that comes back to some of the philosophy I had in sort of Fleura Fertility, where is if you're a good doctor and you provide good medical care, that is enough. And I really think the patient experience and patient journeys are about more than that. They're, about transparency, communication, and these factors are just as important, honestly, in the patient's engagement and journey as the good medical care.
What does self-care realistically look like for you right now?
Yeah, so I think it's consistency. So more than perfection, I would say, staying consistent with sleep and exercise and time management has been a big one for me lately. Yes.
I can understand. It's refreshing to hear what self-care means for you in a sustainable way.
Yeah.
So, Dr. Jen, tell our listeners where they can find you and perhaps schedule a consultation.
Sure. So I am at Fleura Fertility. It's Fleura, FleuraFertility.com. I'm also on Instagram, TikTok, and YouTube, Dr. Jen Fertility.
I'll be sure to include all of this in the show notes. Thank you so much, Dr. Jen. This conversation provides so much clarity for those making fertility decisions.
Thank you so much for having me.
My pleasure.